Well, hey everyone, this is Chris with the Ancient Scholar, and getting off of work. Got off of work, off of work a little while ago. Been doing some studying and some work on my own studies, and I thought I'd just get a little walk in and just record a little video. Check out how the new front-facing camera works on my iPhone 6. In the dark. Frankly, I can't really tell any difference from the 5S, but yeah, there's a lot of interesting hyperbole over all that. But hey, it seems to be working all right. So I figured I'd just go ahead and just do something a little different here. And what I want to do is I want to talk a little bit about making some predictions. I want to predict a couple of things coming up. And specifically what I want to talk about is I want to talk about the American Heart Association, or AHA. And the way the American Heart Association works in regards to their guidelines is every 5 years they will present new emergency cardiovascular care guidelines, or ECC guidelines. And basically what they'll do is they'll release the guidelines. And then about a few years into the 5-year process, the various clinicians, researchers, and teams will get together, and this includes international partners as well. The international committees, liaison committees, and the European Resuscitation Council. So lots of different people, lots of different backgrounds, looking at the science, okay? And so the last update to the American Heart Association's emergency cardiovascular care guidelines occurred in 2010. So the new guidelines will be published around about in the next few months. Because 2015 is coming up. So what I want to do is I want to make a few predictions about the how the guidelines are going to change, we'll say. And I could be totally off here, but I think on a couple points I'm well justified in at least talking about what I'm talking about. So let's go ahead and I'll give you guys my predictions. So I'll specifically focus on the Advanced Cardiovascular Life Support, or ACLS guidelines. And I won't talk a whole lot about PALS, Pediatric Advanced Life Support guidelines. I'll primarily be talking about adults tonight. Okay, so here's my prediction. So number one, the big thing that I think there's going to be a big de-emphasis on therapeutic hypothermia. That's been the big push for the last several years. Big push. A couple of studies came out in the early 2000s looking at a few hundred patients. I think there were two major studies, a couple hundred people apiece. And they looked at patients that were cooled versus patients that weren't, right around 32 to 34 degrees Celsius for 12 to 24 hours, gradually rewarmed. Anybody who takes care of post-arrest patients is probably aware of this. So what they found in those studies is that lots of patients apparently did better when they were cooled. All right, they dropped their temperature. They apparently did better. They had better neurological outcomes, better survival to discharge, etc., etc. Better overall neurological outcomes. And so based on these studies, the guidelines were changed, and there's been a big push for therapeutic hypothermia ever since. However, there have been some critics. And what people have been saying, and I think it's a compelling point to consider, is that perhaps what we're seeing is that we weren't seeing hypothermia per se improving outcomes. What we're seeing is patients that probably would have been febrile, and the fever is what may have led to bad outcomes. And because we're making people hypothermic, we're preventing hyperpyrexia or fever. and it's actually the prevention of hyperpyrexia or fever that improved these outcomes. So it's something interesting and reasonable to consider. Well, in December of 2013, a very large study was published, I believe it's in the New England Journal of Medicine. It's a very large analysis of patients. And it's fairly well done. In fact, there are more patients in this single study than there were in the two big studies that were cited in the guideline changes in 2010. And what they found was there's absolutely no difference in outcomes looking at patients who were cooled to 32, 34 degrees Celsius, right in there, versus patients that were cooled to 34 to 36. So just a very mild hypothermia. Very, very mild indeed. So that was a pretty compelling study. So it's really good quantitative evidence suggesting that, in fact, aggressive hypothermia following ROSC may not be as effective as we once thought. So my prediction is that there's probably going to be a modification to that. I think that their hypothermia will probably still stay around, but I think that they'll probably look at the different temperature thresholds, and there'll probably be on a bigger emphasis on preventing hyperthermia, preventing and aggressively treating fever. Okay, so that's my first prediction. I think that'll be big. Second prediction, I think that the heart rate may increase a little bit. The compression rate for adult compressions. There's some evidence suggesting that maybe rates of 120, 130 with good depth and adequate recoil. So at least 2 inches of depth, adequate recoil, and then fast compressions at a rate of about 120, 130. I'm guessing somewhere around 120. There may be some changes there where right now they're like at least 100, and they may even just go out to say that they would like higher rates, 110, 120. But I do think that there may be some sort of change regarding the rate, that the compression rate for adult patients will increase. I believe that there will probably be some discussion about integration of technology, more technology into arrests. Looks like maybe impedance threshold devices may have a role. The evidence that kind of went away from them. But it looks like there may be some evidence that there's a role there. There's some evidence that perhaps mechanical compression devices may have a role, assuming that you don't interrupt good compressions to place these devices. But I think there's going to be an emphasis on other types of technology that can be used to monitor adequate depth of chest compressions, adequate rate of chest compressions. I think that there probably will be some additional mention about integrating that type of technology into codes. I do believe that there will probably be mention about instituting ECMO, extracorporeal membrane oxygenation therapy, into certain situations. There's some evidence that suggests even in the setting of a prolonged arrest, ECMO may have a role to play in the resuscitation. There have been some good outcomes there. So I think that ECMO may play a more prominent role. I think that perhaps if patients remain in a shockable rhythm, pulses, VTAC, and ventricular fibrillation, that there will probably be some sort of mention or recommendation about continuing that code. There is some evidence to suggest that even prolonged codes, 30, 45 minutes, assuming good chest compressions are being performed, a prolonged code may be appropriate in some patients, and outcomes may actually be good, situation dependent. So I think that will make its way in. Let's see here, talking about medications. This one, this prediction, I'm not as confident about. Anecdotally and from a subjective standpoint that isn't highly evidence based. So this is my opinion, if you will. My opinion is that antidysrhythmic medications don't have much of a role in the resting patient. I really don't see much of a role for antidysrhythmics. We've known for a long time antidysrhythmics have significant pro-dysrhythmic properties. And you're creating a sort of channelopathy when you dump a potassium channel blocker into somebody. So I'm not convinced. And the evidence certainly doesn't suggest that there are improved survival to discharge outcomes with any of the antidysrhythmics, amiodarone, lidocaine, procainamide, etc. I don't know if they will be as bold as to come out and say that. I don't know. I don't know that the evidence. I don't know that there's real compelling evidence that says that it's harmful to give somebody amiodarone. So I don't know. It's kind of a crapshoot. I would just de-emphasize the use of antidysrhythmics. Perhaps if they're bold, they might say that all amiodarone will drop down into that indeterminate evidence category. Well, kind of like where lidocaine is now, where okay, you can use it, but it's not really going to help survival to discharge times. So I don't know. They may not, but if they were bold, I could see them doing that. I could see them de-emphasizing antidysrhythmic medications. I certainly would, but that's just my opinion. So let's see here. I don't know that I foresee any major changes. I think the algorithms will be further simplified. They're already simplified very significantly, certainly much more significantly from when I started practicing clinical healthcare back in the 90s. The mid-90s is where I started. The algorithms were quite complex, and we gave lots of different medications. I do think that certain medications like sodium bicarbonate, calcium chloride, are going to have a role toxicologically when it comes to things like hyperkalemic arrests and things like that. From a toxicology standpoint, I don't see any major changes occurring. There's a lot of talk, and a lot of people are really excited about lipid emulsion therapy. My personal opinion is that I am relatively unconvinced that lipid emulsion therapy is a panacea is the definitive therapy. Certainly, there's a lot of anecdotal evidence out there. A lot of good stories, but not really good evidence. So I don't know that lipid emulsion therapy would make its way into a standard guideline where every toxicological, every lipophilic toxicological overdose patient should be getting it. It's a consideration. There's certainly compelling evidence to suggest that it has worked in some patients, but I don't know that broadly accepting it is appropriate with the amount of evidence that's out there. So that's just my opinion as someone who spent the last couple of years studying toxicology. I could be totally wrong. And I'm certainly open to having my opinion changed, as I think anyone who embraces a skeptical and a skeptical, evidence-based and open open way of life. If you maintain good balance between all that, you should be open to changing your mind when presented with good evidence. So that's my take. I've been blabbing on, kind of a worthless video, pretty poor quality, I think. But I just want to do something totally different, get a little walkout, and get back to my work, pull all-nighter. That's all right. It's Friday, so I have this weekend off, so I'll sleep in a little bit on Saturday. Maybe I'll go a little hike, but I got a lot of studying to do. So those are my predictions for the 2015 American Heart Association Emergency Cardiovascular Care Guidelines. I would be interested to hear or to see what you guys think. Obviously not a lot of people see my videos, but if you have some insight, or you think obviously there's been a series of meetings going on, kind of some pre-guideline release stuff going on. So there's some stuff you can read out on the internet as well. It's probably a lot better than what I could present here. But yeah, hey, if you have an opinion, put your opinion down there and let me know. Let everyone know. All right, guys. I think I'm gonna go ahead and cut it off here. And hey, as always, thanks for hanging in there, guys.